Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Today's program is part of our Disability Education Series, a special collaboration between the Blum Center and Mass General Council on Disabilities Awareness. Before I get started, I just want to go over a few items with you all. Please note that today we have ASL interpretation and live caption provided. This session is also being recorded for educational purposes. They'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has muted so you can hear our guest speakers today. If you have any questions for our guest speakers, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff, our co-hosts, and guest speakers will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I will introduce you all today's guest speakers. Joining us today, we have Sharon Amos and Ellen Silvius. Sharon is formerly an oncology nurse in the Outpatient Cancer Center for many years here at Mass General. Currently, and for the past 2 years, she has been a nurse navigator for the Mass General Comprehensive Sickle Cell Disease Center. Joining us today, we also have Ellen. Ellen is also a nurse navigator in the Mass General Comprehensive Sickle Cell Disease Center. She's been in this role since the center opened in May 2021. In recognition of World Sickle Cell Awareness Day, which is actually tomorrow, they join us today to give a talk on sickle cell disease, a portrait of racism in the American healthcare system. Before I turn it over to them, Zara Emir Hassini, our Disability Program Manager at Mass General, has a few words to share.
Thank you very much, Amy, and welcome everyone. This is our final presentation for this year for disability education. So I just wanted to recognize that, as Amy said, tomorrow is Sickle Cell Anemia Awareness World Recognition Day. So I wanted to just bring in a few points before we introduce Ellen and Sharon for their presentation. So sickle cell disease affects millions of people around the world. Although sickle cell disease has long been associated with Black community, it can also be seen in people of many races. Other groups more likely to have sickle cell anemia include Hispanic Americans of Central and South American descent and people of Middle Eastern, Asian, and Indian heritage. Despite their extensive healthcare needs, many persons with SC are difficulty accessing appropriate care and report feeling stigmatized and having their symptoms dismissed when they seek care. Although the law does not automatically consider SCD a disability, many people with SCD satisfy the legal requirement for disability rights because they frequently experience fatigue and severe pain, which may impact their daily living. We hope that through this presentation, we'll learn more about SCD and challenge myths that stigmatize this population. So without further ado, I'll introduce Ellen and Sharon. Thank you both very much.
Great. Thank you so much, both of you, for your introductions. We really appreciate it. Our presentation today starts with a beautiful image that was created by French artist Jean-Francois Millet. We're borrowing it from Dr. Azar, who's actually an art history major in college. And it's a picture that depicts three women gleaning the field after what appears to be a very successful harvest in the mid-19th century in France. And they are being allowed to gather the leftover harvest remains as they are the poorest of the poor. They're essentially beggars, taking the scraps of the excess bounty of those who are far more fortunate. It's actually the perfect metaphor for the care and attention that has historically been afforded patients with sickle cell disease, who for a century have been marginalized, judged, and othered in a systemically racist medical system because of the color of their skin. I've always been drawn to the care of patients with great needs and few resources, and it never occurred to me that I did not have to travel halfway around the world to do this work. But here at Mass General Hospital, there's an opportunity to do just that every day in the care of patients with sickle cell disease.
So this second slide is sickle cell disease, an overview. It's an inherited life-threatening blood disorder that impacts about 100,000 patients in the United States alone. That number is false. It's been the same for over a century, and we really don't know how many people are affected by this disease, unfortunately. In the US, 4,000 to 5,000 pregnancies annually result in some sort of SCD variant and diagnosed in infancy or in early childhood. The life expectancy is alarmingly short for people with this disease. The average life expectancy is 38 to 45 years. And it's characterized by the hemoglobin, which is the red blood cell component of your blood, that its main function is to provide oxygen to all your tissues and organs. And that red blood cells should be round in shape. And with sickle cell disease, when they have crisis, the cells become C-shaped, making them or rendering them incapable of transporting sufficient amounts of oxygen to the various parts of the body. And so and they also become kind of sticky and impede blood flow. So circulation is also affected. And it can, as you would imagine, that the blood goes through every part of your body, it can affect every organ in the body. So people can have strokes, they can have heart attacks, they can have really just painful different areas of the body, their joints, they can have headaches, they can have pain anywhere you can imagine in the body. And it is one of the few diseases that largely impacts Black and Brown people. And for this reason, it is really unique and almost a social experiment in racism for what would happen if a horrible disease only affected people of color, and how that would progress through time. And unfortunately, there has not been a lot of progress in terms of treatment options, and it's largely supportive care. Okay. And so the clinical manifestations of sickle cell disease, just a closer look of kind of what I described earlier, where the red blood cells are should be round and they become sickled for people who are affected by this. The complications usually are what causes people to come to the hospital, right? It's the pain that brings people in, because it's difficult to manage at home. Often people can take non-steroidals and have like oral opiates that they can kind of manage things at home. But if it becomes too severe, they need to come to the hospital. The peak is usually age 19 to 39, where the disease kind of ratchets up and people will have more frequent episodes of painful BOE crisis. And they are associated with higher mortality, unfortunately. So the more crisis you have, it causes organ damage. Slowly but surely, it can affect your organs, your kidneys, your heart, your lungs, et cetera. So the more frequency you have with these painful episodes, it can really affect the quality of your life and the length of your life. Okay. And also just as an aside, this is a time of your life when people are trying to educate themselves. They're trying to have families and enjoy their lives and keep jobs, and it can really be a hindrance for people to progress and have normal lives if they are frequently ill and hospitalized. It's really hard to keep a job for many people. And this crisis can be triggered by just about anything: stress, cold, hot, infection, stress, again, a menstrual period, alcohol consumption, a number of things can cause you to have an acute crisis. And sometimes people don't even know what causes these VOEs. And an important thing to note is that there's no lab test that can definitively diagnose a veno-occlusive episode, right? So then that is kind of tricky for medical providers who were very data-driven, and there's no way to prove. You have to rely on the patient's own report. And often people don't look like they're in pain, in quotes, right? But it begs the question, what does pain look like? And people who live with pain chronically are going to present in a different way than folks who are having, an acute pain episode that they're not used to. Next slide. Mm-hmm. And I'll just also add here that for people of color, interacting with the healthcare system can be quite challenging. There is a lot of bias that unfortunately is real, and we don't have the benefit of the doubt often when we arrive to the hospital. The opiate crisis has not helped that. And historically, film and media have portrayed people of color to be criminals and to be kind of just portrayed us in a really negative light. And if you do not know a lot of people of color, that is the image that you are left with. And it does implicitly affect the way you view people, all of us, right? You don't have a frame of reference, and it can be really damaging. The way we have been portrayed historically, it doesn't help. So when people come to the hospital, they have tried everything. They've exhausted every home remedy, and they really need to be here. So I just wanted to stress that point. So as I kind of touched on earlier, stressing the point about our blood and how we take it for granted, and our bodies need it to function. And if there is a problem with the circulation or the shapes of your red blood cells, it's going to affect every organ in your body, right? So your bones, your kidneys, your brain, your heart, lungs, eyes. We have had people go blind because they've had a stroke in their eye. People have had painful ulcers that are really hard to heal. There's painful priapism for men and infertility for women. So any complication that you can imagine where a part of the body needs blood, that it's possible for these very young people. It can be really challenging to manage, and a harsh reality for them to accept. Next slide. So the pain of sickle cell disease, it's been described as the feeling of hot pokers running through their body, or the feeling of their bones breaking from the inside out, or the feeling of glass running through their veins. I think a good way for people to possibly relate to some level is if you would imagine what a heart attack is, right? So it's there's usually a blood clot that's blocking the circulation through your pulmonary artery, and this causes your heart tissue to die, and that causes the crushing pain that people describe. And if you can kind of imagine that happening in different parts of your body, I think it's an easier way to kind of conceptualize what this pain might be like. It's basically tissue death. And of course, it's quite painful for these folks. And again, there's no lab tests that can diagnose this. It's really just happening. If when patients have pain that's really unusual for them and comes on suddenly and like they've never experienced before, we kind of do imaging to see if there's osteonecrosis, which is bone death. We check to see if there's a pulmonary embolism. We definitely screen it for heart attacks and strokes and things of that nature. So we have to rule all of these things out. So when people come in with pain, we take it very seriously. These patients can be really medically complex, and we have to provide supportive care, medical care. They really can be medically complex. Into this. All right, so treatment and management of sickle cell disease. And like I said, this is essentially supportive care. It's palliative care. There are a few oral agents that we use to kind of minimize the number of sickle cell crisis that people have. The most effective is hydroxyurea, which is our number one there, and it stimulates the production of hemoglobin F, which minimizes the sickling of the cells. And we're all born with hemoglobin F as infants, and that disappears in about 6 to 12 months. But for patients with sickle cell disease, having hemoglobin F is really protective in preventing all of these crisis and organ damage that can take place. L-glutamine, which has shown to decrease hospitalizations when used with hydroxyurea. That, unfortunately, is very unpleasant to take. It's like a powder that is mixed into a fluid, and it's like a really thick, unpleasant, solid medicine that people, it's really hard for them to tolerate it. Voxelotor raises the hemoglobin by 1 point and really has no impact on veno-occlusive episodes. Crizanlizumab, which was really promising a couple of years ago, and it was approved for the prevention of veno-occlusive episodes. Unfortunately, in the most recent data, has shown to be no better than placebo. So it really, we were really hopeful about this drug, and unfortunately, it just has not panned out to be as helpful as we'd hoped. Also, so in terms of cure, the only cure that is available is through a bone marrow transplant, right? And that would require a donor, someone that is matched, and it's best done in the pediatric setting. So there's bone marrow transplant and gene therapy. Gene therapy is a disease-modifying treatment that is new and exciting, coming down the pike right now, and we have our first patient going through gene therapy. But it is again not a cure; it is disease-modifying. So it turns on hemoglobin F in people who their genes are modified, and hemoglobin F is turned on, and so that, as I described, would help to minimize the number of sickle cell crisis, and then thus giving people a better quality of life. However, it does not reverse any damage that's been done to your organs, neither of these treatments. Bone marrow transplant has a lot more risk in terms of rejection and possibly, people not having any improvement with their disease, with their organ damage, unfortunately. So it's best done in the pediatric stage, and is actually considered experimental past a certain age because the damage that's been done will not be reversed. Next slide.
I guess that's it. Okay, sorry about that. Having, again, technical difficulties. Okay, can you all hear me? I hope. So as Zari had touched on, the epidemiology of this disease, the incidence and distribution, in other words, is global. It's actually most prevalent in sub-Saharan Africa and India, with India having the highest per capita incident in the world, close to actually over 1 million. Close to 3/4 of the patients with sickle cell disease live in sub-Saharan Africa, which also has some of the poorest access to healthcare of any sort. It translates into this poor access and basic diagnostics and treatment to being non-existent. And that leads to some of the highest mortality rates for this disease. So where Sharon mentioned that the disease process goes, the average in the United States, for example, is up to 45 years old. It's actually far less than that in these types of countries. And it's also worth noting, because Sharon kind of touched on it, that the number of sickle cell patients in the US is kind of a made up number. It's worth noting that the global paucity of the data collection, because nobody has paid attention to this disease since in the last 100 years that it's been actually discovered, it means that there's significant gaps in data and statistics and analysis. So this is in much need of being looked at further, but that's what we have currently. Next slide. So the epidemiology breakdown in the US is highlighted in this slide. And we're looking at 3 different genetic-based diseases: sickle cell disease, cystic fibrosis, and hemophilia, all of which are lifelong and absolutely devastating in their own right. The sickle cell population, there's 4,500 patients a year, roughly, that have some type of disease variant, compared to 2,500 of cystic fibrosis babies per year, which is, and also hemophilia, which is even lower, lower incidence, 400 babies roughly a year. Cystic fibrosis is a disease that affects Caucasian babies. So it's garnered a lot of medical research and development, shifting the longitudinal health outcomes of this unfortunate disease in a positive light for those patients. Hemophilia benefits from federally funded 340B program. Mass General actually has a 340B program, and it's a very unique federally funded program that allows patients and families to buy the blood factor that they need to keep their blood in some type of normal state and to survive at a drastically reduced price. And this also has the surplus cash from this that is able to further fund patients that actually have this disease. And it goes to the centers and the staffing that runs these programs, the hemophilia centers. Actually, sickle cell disease has tried to become some type of an arm of this, but thus far has been refused to have anything to do with it and thereby benefit from it. And the highest incidence, yet the least amount of attention and resources is, of course, to sickle cell disease. And yet it was the first genetic-based disease discovered in the early 20th century. In fact, the first image of a sickled cell was taken right here at Mass General Hospital. And if you've ever walked by the Russell Museum, the Cambridge Street, there's actually an image that was taken by, I believe it was an anesthesiologist here, and it's prominently displayed at Mass General, and yet nobody took care of these adult patients in any significant way until Dr. Azar arrived in the year 2020. Next slide. Back. There you go. So, you know, the inequitability of this disease, if that's even a word, is laid bare in this particular slide. These are cystic fibrosis, again, I'm mentioning it because as a point of comparison, it is a horrendous disease, and it affects babies from birth, as similar as it is genetically based as sickle cell disease is. And yet it is outspent, and despite the higher prevalence of sickle cell disease annually in the United States, in all of these categories listed: NIH funding, publications, trials, and disease-specific medications. We still have just the one, which is hydroxyurea currently. There's the hydroxyurea was approved in 1999, and there's nothing specific that has been offered since then, since Sharon just touched on. And the CDC is just now beginning to gather data about sickle cell disease on the scale that it has done so for hemophilia. And there's new efforts by the ASH, which is the American Society of Hemophilia, and the NIH and local and federal governments to shift this needle, but we are so far behind that it will take quite a bit of work to get that done. Next slide. So this disease and the care of patients of this disease is rooted very deep in history. A great deal of mistrust of patients with has come towards health providers, has come from stories based on the history of how they've been treated or mistreated historically. In many cases, not treated at all. The Tuskegee study, which was led by the US Public Health Service back in the 1930s, and the harvesting of cells from cancer patient Henrietta Lacks, those cells which are still used to this day in cancer care and treatment and discovery, in both instances, without patient consent or full disclosure, has created a mistrust in medical care providers that exists to this day. Dr. Marion Sims, who's considered the father of modern gynecology, operated on enslaved Black women without consent or anesthesia, as he believed that they did not have the same pain threshold that white women did. And this belief has permeated to this day in the care of patients of color, not just sickle cell patients, patients of color in general. And as far as no treatment, the post-Civil War Memphis actually saw a diaspora of former slaves coming through that city and settling in that city. And in the segregated South, they weren't allowed in the hospitals. Patients of color were not allowed for the most part at all. And so patients with sickle cell care sought treatment and help from their local churches. That was where the people that were of like mind and like circumstances would gather. And so there was a general knowledge based in the churches. And so that was historically where they would go for any type of care. And in the 1960s, St. Jude Hospital, which I know a lot of people are familiar with cancer, but it was actually brought to existence because of care of sickle cell patients as well by Danny Thomas, who was a then well-known actor and comedian, was one of the only places where children of color were allowed to be seen and treated. And he was met with intense resistance by the Jim Crow South for insisting on that, but he refused to move forward on opening it until it was allowed, and ultimately that became the case. And it's now a world-known treatment center for patients still with sickle cell disease, but more prominently now known for cancer. Next slide. So in the Jim Crow era, the paradigm was separate but equal. And even though most Jim Crow laws were rescinded eventually, this is a key example of where it is still in place. That institutions or cancer centers, the medical system, claim that our resources are equal to what other diseases have, but equality is not equity. And unless we have equity, we're never going to catch up. It's not enough for us to have the same amount of clinic spaces as CF or the same number of support staff as colon cancer. We really have to reach for equal footing, and that's equity. To have nurses that are caring for our patients that actually understand and want to treat and care for our patients versus nurses who are perhaps more based in cancer or other types of care. If there's a very specific need and understanding of these patients, and they deserve to have a type of staffing that actually understands and treats them. And it really underscores the fact that you must care for the least of our patients or you're not caring for anyone. Next slide. Sharon.
Yes.
Let me turn that.
So
Sorry. Go for it.
as we are celebrating Juneteenth, 1865. June 19th was the Emancipation Proclamation, which kind of ended slavery in the United States. Unfortunately, it ushered in Jim Crow, which was segregation, discrimination, disenfranchisement of Black people. And a part of that was the redlining that was created, where there were maps drawn that relegated people of color to certain areas where there were food deserts, poor schools, underfunding, low income, air, water, and noise pollution. So this kind of perpetuates the lack of progress that was allowed for people of color. So no, we're not enslaved, but we are kind of relegated to the lowest rungs of society, and our ability to progress is very much stifled. And also, at that point, we were criminalized. Everything we did was made illegal. So that also brought in the prison, the for-profit prison system that is still in place today. So it's really important to understand the history. I think we live in modern times, and if you're not connected or do not learn about the history of this country or any other country, you don't really have an understanding of why things are the way they are. And I think that kind of helps to allow people to be more thoughtful in their interactions with people that don't look like them, and just have a different thought process around how things came to be for people of color in this country. It was very intentional, and the system was designed and works the way it is supposed to work, to keep certain people oppressed and on the fringes of society. Yeah. And so, if you have a chronic illness, such as sickle cell disease, and you're a person of color and you're relegated to these places, it makes your suffering tenfold, right? So you don't have access to healthcare. I have been a nurse for a really long time. I won't say how long, but a really long time. And for me, I only know so much about sickle cell disease as a person of color because this sickle cell center came to be in my oncology unit 4 years ago. And, I had a very limited awareness about the disease and how deadly it can be, how painful and the suffering that people go through, and with very little resources and frankly, medical. Again, it's supportive care. There's very little treatment for the actual disease itself. And, again, if you have, so it's a vicious cycle. We find that we have over roughly 255 patients in our center that we care for. And of course, it's people who have social determinants that are not, ideal, that are suffering the most. Right. So we talked about how stress can affect a patient's getting crisis and having complications with this disease in particular. I mean, in general, the general population of people of color, our life expectancy is lower than white people in this country, just to be frank. And that is because of social determinants and systemic and structural racism, unfortunately. So again, it's a bit repetitive, but it begs repeating that the social determinants and the deep-rooted racism in this country really affects the lifespan and the quality of life of people of color, especially.
Next slide.
Next slide, please. Okay. So this is just kind of a graph of what I kind of just described, right? So again, the expectancy is lower for people with sickle cell disease. It's lower for people of color in general, because of the history of this country and kind of how we're where we're relegated to geographically. And it goes without saying, right? People with sickle cell disease are at the lowest point here, with the life expectancy being the lowest. And hydroxyurea it's a chemotherapy an oral chemotherapy that is kind of outdated, but this particular drug helps to keep people pain-free and without crisis. And it's a hard sell. It's better if it's given and started in a pediatric setting, but it's a hard sell for Black parents who, when your child with sickle cell disease is young, they seem okay, and they may or may not have pain a lot. So it's a hard sell to give your child chemotherapy, but we've had it for a really long time, and it has been shown to be the single most effective thing for prolonging people's lives and having them be able to function, without having severe crisis often, which, as I described before, it prevents you from holding a job, prevents you from getting an education, prevents you from having a normal family life. So, again, it bears repeating that, people of color kind of tend to lag behind in terms of progress and health and wealth and pretty much every aspect of life. Next slide.
Next slide.
Okay.
So I'm going to have to ask you to hit this a couple of times, but not all, just little bits. Well, just let it go. It's fine.
Let it rip.
I'm just going to let it go. So the case in point of what Sharon's just speaking to is our dear patient, Jeff. So he's a 30-year-old man who has hemoglobin SS disease, got a childhood history of strokes. He has osteonecrosis, the bone death, so joints are not well. He has a history of pulmonary embolus and deep venous thrombosis, hyperhemolysis, which is something can happen with frequent blood transfusions. Since he's had this since childhood, he, like many of our patients, suffer from depression, post-traumatic stress disorder, anxiety. It's another one of these threads. He has struggled greatly with mistrust of his providers. He actually came to us 2 years ago, I think it was. And, I actually had this conversation with him not terribly long ago, like last week. And I said, we were kind of marveling at the change in him since he has come with us. He was almost like a neglected animal when we met him. He wouldn't give us any eye contact. And it was all from years of being treated as an other, especially not as a child as much, but once they come into adolescence and they come to look like a young Black man, there's a judgment and attitude that's made out of them. And it's another one of these threads that kind of follows through their life, where Dr. Azar says there's a great deal of suffering that goes on with sickle cell disease, and there's a lot of different threads to that. And this is definitely one of the threads. You could maybe hit it again, Amy. So it creates challenges in a young person's life. I mean, like Sharon said, they're at the precipice of their young adulthood. They're trying to have a relationship. How are they having a job when their schooling has been disturbed by frequent absences, and maybe their confidence is lower? They're unable to complete school, so now they can't get a job that can actually afford them to live in a city that, as we all know, is terribly expensive. You can hit it again. And we're trying to cure all of this with Dilaudid and hydroxyurea, and it doesn't work because it's not exactly the right answer, but it's really all we have right now. So us showing up for our patients is one of the best things that we can possibly do. We create safe space for our patients. We honor who they are, and we believe them, and they come to believe in us, and they will share with us so that we can help them with some of the stresses that they have in their life. And bring, if we don't have the answer, we try to bring those answers to them and integrate them with the folks that can actually help them. Next slide. Oh, yeah, go ahead. I'll give you, I'm going to leave you hanging there. I have a little follow-up to Jeffrey, but I'll let Sharon go right now.
So this may seem a bit repetitive, but again, I think it bears repeating that social determinants really affect the course of people's lives, Black, white, brown, whatever, they just do, right? So people of color in particular, as I've said before, are kind of at the bottom of the pile, unfortunately. And, you know, like we said, deep-rooted systemic racism, so socioeconomic inequities and implicit bias, whether you realize it or not, we all have bias. You know, that it's undeniable and we don't even realize it's there. So, you know, if we could just try to have some awareness around that. None of us are perfect. We're all trying to do the best we can, you know, with what we have to try to work with folks who are living with this horrible illness. And again, this disease, the gene mutation has been, we've known about it for over a century, and you know, again, this is a social experiment for what would happen if something affected only people of color, like what the progress would look like. And it's a glaring, I think, I'm going to call it a stain on, you know, the medical community. And you know, I think there's a reckoning that needs to happen around this disease. There's so many people that are living with it. And I said, I mentioned before that we don't know exactly how many people have this disease in the country. And that is because only in recently in 2006 were people required to report or screen for sickle cell disease in this country, all states, right? And from state to state, that has, you know, people may or may not follow through, you know, just based on kind of what's important to them. So there's no mandate around how that information is communicated and, you know, what is actually done about it. There are 70 sickle cell centers across the country. Not so much in the middle of the country. They're on the coasts, basically. So, you know, where people live and the kind of care that they get it's really important. And especially as people get older, pediatric care is better because kids are cute and people want to help kids. But once they come into adulthood, the transition can often not happen and people can be lost to follow-up. They have a hard time interacting with the healthcare system. You come to the emergency room, you're young, you look healthy. Why are you here? You must be drug seeking, right? And so, and this is, you know, this picture really speaks to how particularly women of color feel when they are, you know, just existing in this world. They feel misunderstood, unseen, and unheard, and especially if you have a life-threatening illness. So it really, we're really proud and happy to, I feel really honored to be a part of this work. It feels like we're kind of the thread that's missing. We don't necessarily have a cure, but we listen to folks, we believe them, we communicate with them, we care about what happens to them, and they know that. And that in and of itself, it's not a pill, but it's a therapeutic relationship that we have. And you know, like I said, I've been an oncology nurse for a really long time, and oncology was easy. As awful as it was easy because I did not worry about my patients not getting what they needed. That was, it's like fantasy island. They're gonna get what they need. It may take a little time, but you know, I went to bed not worrying about my cancer patients. I know that disease is well funded, recognized, researched, everything that you could possibly need. I mean, I'm not minimizing cancer, but it is fully funded and respected, and people get what they need. We've had so many advances that it's just a chronic condition for many people now if caught early enough. So I would like to have the same, have our patients with sickle cell disease have the same care and attention and investment because their lives matter. And They are some of the most wonderful people you would ever want to meet once you get past the fear and the distrust and the trauma, and really get to know them. All right, next slide.
My volume there. What is it? Sorry about that. So this slide really speaks to what Sharon's just kind of touching on as well. I think the overscore here is the social determinant issues that overshadow most of our patient population. They have a lifetime of schooling that's fractured right from the very beginning. They don't get to make the social connections with some of their peers. They don't necessarily get to participate in some of the things that their friends are doing because their bodies don't necessarily cooperate. They want to go hang out with their friends. They want to go swimming. They want to go to camp. They'd like to go to sports, dating when they get a little bit over, vacations. All of those things, as Sharon had touched on earlier, can actually set off a crisis, and they don't, or nothing. They don't even know when. So they have to really be thoughtful and about where they're heading, and if they aren't, then it actually can come back to haunt them, because now they have to get care in a hospital that doesn't understand them, which frankly, you just go a little bit west of Boston, and we're not even talking anywhere very, very far away. The care is just not the same. The organ damage over a lifetime with the stroke possibilities, it impacts cognitively. We have a number of patients that struggle with that. Patients in their 20s having heart attacks, not really even quite understanding, what do you mean I had a heart attack? I'm only 25. With their adolescence. So we're kind of pulling these adolescents up into adulthood with a disease that is about the cruelest thing that I've ever been a party to in my, like Sharon said, very long time of being a nurse and doing so many different things in nursing. A lot of them suffer from mood disorders. Who wouldn't? I mean, you're trying to live your best life and you keep getting stopped. We have one of our patients, actually it was Jeff, said, every time I have an event to go to, a wedding, a party, any type of gathering, I talk to it, I negotiate with it. Okay, just please let me be okay at least through Saturday. You can just hit me at the end of Saturday, but just can we please just be okay till I get there? And that's a very real thing that happens with a lot of our patients. And they just have a perpetual sense of being devalued and diminished, because when they come into the emergency room, we could tell you stories. We won't get into all of them right now, but every day there's some things that go down in this hospital right here that would just shock you in terms of how our patients are perceived and treated. The good news is that we've shifted some of that because we've done a lot of teaching, and we show up, and so we kind of help people to take the best care of our patients. But it is not always the case, and it leaves us feeling very uneasy at the end of the day, hoping that nothing happens while we're not here. Because we have no control of what happens when we're at home sometimes. So, and there's also fallout on families. I mean, if your child is sick, then how are you going to work? Somebody has to stay home. So maybe there's a single parent. Maybe there are two parents, but somebody has to pull back. They have a lack of childcare, and then it creates economic hardships. I actually was on a seminar once where one of the patients spoke to the fact that actually was a mom, spoke to the fact that her own mother was brought in to take care of their child when they were sick and younger, and it created a hardship for her parent, because when she got into the retirement age, she had no retirement because she was working, if you will, for her grandchild. So it's not just the patient. This has far-reaching consequences, this disease, and our patients suffer on so many different levels. One of our patients, this is a direct quote, when in a panel discussion that we had in the O'Keefe Auditorium, when she was being questioned and asked, what is it like to have this disease and how does she feel when she comes to the hospital sometimes? And she said, I have a voice, but nobody's listening. And that has sat with me so many times, and I've seen it play out so many times. So oftentimes Sharon and I we're doing medicine, we're doing social justice work. We are showing up for people, because if we don't, they may be treated poorly. We've seen it happen when we're standing there. So you'd think that we're at a hospital where those types of things might not happen. People will work at a very high level, but it just goes to show you the depths of our own prejudices and our own racism, frankly, is what it amounts to. We don't even realize it sometimes, but we're here to bring it to light and to keep showing up and to be a presence for our patients. Next slide.
Yeah, so this kind of speaks to kind of piggybacking on what Ellen said about provider behavior and attitudes to patients. And this is a study was done where there were medical students, internal medicine or ED residents. They were presented with one of two medical record notes that differed only in the way they described the pain and asked to choose from 4 options for pain control. And those who read notes with biased language were more likely to select a less aggressive pain regimen and held a more negative attitude towards a patient. And further along in the training, the more further along they went in training, the more negative the attitude. So, you know, it just speaks to how our attitude and our behavior, and, you know, again, we have biases that we don't even realize. And sometimes just, you know, kind of the way you say something or how you kind of dismiss someone and kind of, you know, minimize their symptoms, or, you know, again, people of color unfortunately do not have the benefit of the doubt. So it doesn't take much for people's the way they view them or treat them to kind of shift. So you know, it's important to have awareness around this, and you know, no one is perfect, and no one wants to be on the receiving end of, you know, for lack of a better term, a bad provider, or a provider that you don't feel like you're getting the most or the best from. And so it's really, especially with people of color, it's important to be mindful about how we describe things, and how we, you know, just have an open mind, and think about whether you are giving this person the benefit of the doubt, because you may not even realize that you're not. It's really easy to believe bad things about people of color, unfortunately, because of, you know, our history in this country. Next slide. Okay. And again, this is just piggybacking off of the last slide. Surveys that felt that hematologists believed that people were addicted to opiates, and did not believe the patient's own self-report of their pain was the best indicator of the pain. And just to make the point that the SCD pain is, it's a patient's report. There's no test that can teach it. And this is some language that's used that we try to avoid: sickler, frequent flyer, drug seeker. And next. Okay.
So we will wrap it up here. I know we're very close to the end. We have so much to say, obviously, and there's more, but briefly, the next slide is a picture of our team. It just underscores the amount of people and the expertise that are needed to be able to manage patients who have so many different issues, as we've already touched on. It's very, very complicated, and it requires a lot of specialists and people that are actually vested in the actual process. Next slide. Next couple of slides. Do you want to?
So we're really excited about this. There, you know, all the hard work that we're doing as a community, in the sickle cell community here, and, you know, across the country, is panning out. So in this region in particular, there's an act that is moving through the House now, and is actually making great progress. Well, it's an act to improve sickle cell care. And these are just kind of some things that we're hoping to accomplish that would be in place throughout the Commonwealth, which would be really exciting. And a registry a standard of care that the state would help to finance, fertility preservation for people undergoing transplant or gene therapy. That's huge, because often with the chemotherapy that's needed with gene therapy and transplant, that would render people infertile. So you have to decide whether you want to try to get cured or have a child and keep the disease. That's a really hard choice for people, young people, to make. Okay, and also support services to overcome barriers, including housing, food insecurity, and childcare. So we're really excited about this. It's very successful, and we're keeping fingers crossed that everything will come to pass. Next slide. Okay. I'll let you, yes. It is. We'll just let's quickly say a medical provider's role in politics is huge. we need your voices. And this is Charles' quote, that you don't need to understand politics, and in parentheses, our politicians don't. So if you believe in something and you want to make a difference and make a change, you're in your everyday work, you're seeing things that are not just, or you would like to see change, definitely use your voice and join the fight to improve care and standards of care, especially for this disease and many others. Okay, next slide.
Just one last, Jeffrey, I just wanted to let you know, the young man that I mentioned earlier left the hospital last year, flew to Australia, proposed to his then girlfriend, and is now engaged, and feels like we are his medical family. So that to us is gold. And like Sharon said earlier, we're honored to be a part of this work. Thank you. Sorry, we talked to 101. We don't really have time for questions. So sorry.
Thank you so much. We do have one question, if you don't mind, if you have time for it. What are some resources that you can share within the MGH or even around the community for patients and families, caregivers regarding sickle cell?
So the next couple of slides down, there's actually some books that we have found are helpful, I think, in the care and the kind of understanding this disease and people's unknown or unrecognized racial biases. The second one in there was actually written by one of our patients who is since deceased, but if there's a couple of them dying in the City of Blues, I actually referenced some of the material from that. There's a couple more slides after this, and there's more books, but there's also a number of articles, and there's a couple of an amazing documentary that's on Netflix, Who We Are. I can't recommend it highly enough. The Mass Sickle Cell Association has extraordinary resources for patients. We partner with them quite a bit, and they're on Instagram. So we actually tell a lot of our patients, please get on Instagram. Are you on Instagram? Well, then please follow them, because all these resources are there for them. But it's a very good question where, I mean, I think there's had been a dearth of it. So we're trying to get the word out to people. But I think probably just generally the Mass Sickle Cell Association is great, but please feel free to share any of the other things that we have here listed. There's right down below, yeah, the resources. There's some really good stuff in there. And people have any questions, they can always email us, and we're happy to share anything that we may have missed, or if anybody has any other questions about.
Thank you. For anyone who is interested, feel free to email pflc@partners.org. That's the email to the Blum Center, and we'd be happy to share any of the resources shared in today's slide deck, and I'll enter that in the chat as well. And just a reminder that today's program is being recorded. It will be made available on the Blum Center website at masschannel.org Blum Center. Sorry, I just forgot the email. Thank you so much, everyone.
Okay, thank you so much. Bye-bye.
Take care.